Fibrinolysis during liver transplantation. What is the minimal effective dose if we need to treat it? The objective of this presentation is to look into the incidence of cause of fibrinolysis, 2 case presentations, and if we need to treat fibrinolysis, what is the dose for antifibrinolytic agents, and how we can find out the dose in a Vivo analysis. So what we know already is that fibrinolysis is most common during the reperfusion phase of liver transplantation, and that's been followed by the anhepatic phase. It occurs in about 30 to 50% of patients with end-stage liver disease. High levels of tissue plasminogen activator and low levels of plasminogen activator inhibitor have been identified as the cause. It is mostly self-limiting, especially in living donor liver transplantation, and it's more frequent with donation after cardiac death than donation after brain death. And treatment is rarely indicated. So the first case is a 39-year-old female with alcohol-related cirrhosis. She had a past medical history of esophageal varices and bleeding, anemia, and ascites, and the MELD score was 23. This is the interrupt course of the liver transplantation. The surgical start time was 12:30. Fibrinolysis occurred in the patient at about 1:30, and we recognized that on the ROTEM at about 2:30. So there's 1 hour delay because it takes about 60 minutes until the test is completed on the ROTEM. So this page shows you the ROTEM that was drawn during the dissection phase. This is the baseline that was drawn just after the surgical start time of 12:30. The second one was drawn 60 minutes after the dissection phase. 1 stands for the dissection phase and 60 stands for 60 minutes. And the time was at 1:30. So the ROTEM blood sample, the analysis time was starting at 1:30, but the detection of fibrinolysis is 60 minutes later at 2:30. And those are very important times that need to be distinguished very clearly. So one more time, the fibrinolysis occurred at 1:30 in the patient, but we saw it on the ROTEM at 2:30. And the time points are different because it takes about 60 minutes based on the setting of the ROTEM to complete it. And what we see on the ROTEM is what happens 60 minutes before. Sometimes fibrinolysis can start very early on and it's completed before 60 minutes. And at that case, the time difference is shorter. However, sometimes fibrinolysis does not occur in 60 minutes and may start after 60 minutes. In that cases, you will not see that on the analyzer because the default setting is about 60 minutes. And in this case, we see that fibrinolysis started around 48 minutes and it has not been completed by 60 minutes. So when we detect fibrinolysis, what is the next step? Is it to treat it with an antifibrinolytic agent? Or should we repeat the ROTEM? Looking into this action cycle, we are detecting a problem. And before we move on to the intervention, we should analyze the problem. And after the intervention, we should do a reassessment of the problem. So following this concept, to evaluate the minimal effective dose of the antifibrinolytic agent, ROTEM should be repeated before the administration. So we did repeat the ROTEM first, and once the ROTEM was running, we gave an antifibrinolytic agent. This is amikacoric acid or Amicar, and we give a small dose, 1 cc, which is 250 milligram. And the question is, why did we give so little? And the answer to that is there are no studies that look into the dosing for any kind of antifibrinolytic agents in liver transplantation to correct fibrinolysis. So since we have no data and we don't know the dose, the safest dose is to give 1 cc at a time. And to evaluate the effect, the best way is to give it every 5 minutes, to run a ROTEM, give 1 cc, run another ROTEM, give 1 cc, then run another ROTEM and give 1 cc. This way you can see at what dose and concentration the patient's fibrinolysis is fully reversed, and that's how you do an assessment in Vivo. So this is the repeat ROTEM before the administration of Amicar. We already moved into the anapatic phase. The surgeon was moving quickly. The time is 2:31. And just to recap, the ROTEM blood sample analysis at 1:30, that's when the patient had fibrinolysis. We saw it at 2:30, and now 1 minute later at 2:31, we repeated the ROTEM. 1 minute after that, at 2:32, we gave Amicar 1 cc, which is 250 milligrams. And then we did run a ROTEM 1 hour later, and that shows there's no more fibrinolysis. The reason why we did not follow a 5-minute ROTEM 1 cc antifibrinolytic administration is because we did it in the past and all patients did not have fibrinolysis even after the first dose, and the first dose was also not needed because it resolved on its own. This is the ROTEM on reperfusion. This is a NATEM, an APTEM, and a HEPTEM. We can see there's no more fibrinolysis. As I mentioned before, there's a very small chance if the fibrinolysis occurs after 60 minutes that's not being captured on the ROTEM because the setting is 60 minutes. We might see a little bit of a heparin effect. However, it's hard to tell because HEPTEM ideally needs to be compared with an INTEM, and in this case we use a NATEM. So the second case is very similar. The only difference is we gave preemptive Amicar 1 cc, which is again 250 milligrams, and the patient had fibrinolysis in the middle of the dissection phase. Again, very clearly to distinguish, fibrinolysis occurred in the patient during the dissection phase in the middle of it, and it was detected more at the end 60 minutes afterwards. And again, we give Amicar 1 cc 250 milligrams after repeating the ROTEM. So A is the baseline ROTEM before the incision. B is when we saw the fibrinolysis. This is 1 hour after the patient actually had fibrinolysis. We did repeat the ROTEM before administering any antifibrinolytics, and that shows fibrinolysis is completely resolved on its own. We did give 1 cc of 250 milligram Amicar, and this is the repeat NATEM. It shows there's no more fibrinolysis. So in this case, also we confirm that antifibrinolytic was not needed, and we gave a very small dose. So in conclusion, did we need to treat it, or did we cause more harm? And the answer to that is, in both cases, fibrinolysis was self-limiting. Antifibrinolytic was not indicated. We gave a small dose of 1 cc of Amicar, which is 250 milligrams, and we presumably did cause minimal harm by giving a small dose.